But the multifocal, okay, a foci is a shape, okay, or a focus. Foci is plural, but if you have a focus, that's a shape. So multifocal is many shapes. And what we notice there again is the P waves have many shapes, okay? The difference between multifocal atrial tachycardia and wandering atrial pacemaker is the heart rate, but the rhythm may look the same, okay? See how quickly we're able to breeze through this, because now we're just kind of going into things that are deviations from normal. Now, let's go into a-fib. All right, so remember, what do we know about a-fib so far? We know that a-fib, b-fib, any kind of fib are the irregularly irregular. So let's go ahead and say that. We know that a-fib is irregularly irregular. Okay, just like v-fib. Now, what is a-fib? So a-fib is where in the atria, we do not have coordinated contraction. So remember, we're supposed to have rest, depolarization, contraction, repolarization, right? Well, we don't have coordinated contraction. So we don't have the SA node producing the impulse that makes everything beat like normally. What's happening is the atria are now just sitting there, just kind of quivering as opposed to contracting. So we have this kind of quivering of the atria. Now let's think about this. So that if the atria are not actually contracting properly to keep moving blood, what's going to happen is now blood starts to become stagnant. One thing I do want to point out here is a-fib most often originates in the left atrium, whereas most of the atrial abnormalities originate in the right atrium. So even though I drew it as their pacemakers, for instance, all over the atrium, actually, I want to clean this up a little to show you that more often, for instance, let's say for wandering atrial pacemaker, it's more often than not originating from the right atrium. The same with multifocal atrial tachycardia, it's more often than not originating from the right atrium. However, in a-fib, a fair majority of the time, there's an issue with the pacemaker site or a focus in the left atrium. Okay, so for instance, the left atrium that's producing the left atrial pacemaker that's causing the a-fib, that's where a lot of the cardiac ablation will need to take place. So the other thing that you're going to notice with a-fib is you have no discernible P waves. So you can't really make out P waves. They're kind of there, but they don't look normal. Remember, a normal P wave should precede a QRS and it should be upright and rounded. We don't really have that. The other thing you're going to notice is changing that the reason it's I'm starting to get tongue-tied. The reason it's irregular is because the distance from the R to R interval is changing. Sometimes the R to R's are normal, sometimes they're far apart, sometimes they're close together, but the R to R is constantly changing and we have no discernible P waves. Okay, so we're going to say varying R to R. Varying R to R. Okay, that's a-fib. Obviously, if we have this blood that's just kind of sitting here and not contracting well, it's going to, stagnant blood can lead to a clot. We remember from the clotting cascade and from the prostaglandin synthesis pathway. So for instance, all right, I'm not going to go far in depth with this, but remember how we have this membrane, that's made up of fatty acids and phospholipids, for instance. And then we go through this whole pathway where we go from, for instance, the membrane, and then we make arachidonic acid. And you remember how the enzyme we need there is a phospholipase A2, for instance. And then what inhibits that step? That's going to be steroids, right? I told you there are 5 actions of steroids. Remember that? I said, what are the 5 actions of steroids? Remember I gave you the KISS mnemonic. It inhibits uh, T cells and macrophages. No, I'm sorry. It inhibits phospholipase A2, which is the step I just said. It inhibits phospholipase A2. It kills T cells and eosinophils. It inhibits macrophage migration. It stabilizes the endothelium and then stabilizes the mast cell. Those are the actions of steroids. But remember how, so this process that I'm describing, though, this pathway is the prostaglandin synthesis pathway. Well, after we make arachidonic acid, we're going to do PGG2, PGH2, PGI2, and then we can go on and make things like thromboxane A2. We can make other prostacyclins and so forth. But this is the pathway that's needed for clots to form. So one of the reasons we're going to put this patient on some kind of anticoagulant is because this normal pathway is supposed to happen, but we're trying to prevent this pathway by using certain medications. So the anticoagulants are actually working along this pathway to prevent the clots. So what we know is with a-fib, they're often going to be on anticoagulants. Blood levels will need to be monitored. And then depending on the heart rate, we may have to do something for rate control as well. So we know that, for instance, let's say down here in the ventricles, one of the receptors is a beta receptor, for instance, a beta 1 receptor. Well, if we have too much activity, too much sympathetic activity, too much, so the conversion of ATP to pKa with adenylyl cyclase, too much of that sympathetic activity and that beta activity, we need to counteract that with a beta blocker, for instance. So for rate control for a-fib, we could use a beta blocker. We could use a calcium channel blocker. There again, guys, when you know more about the basics, you'll be able to know more about everything. So I don't want you to just memorize rhythms. I want you to really understand. Remember how I did on day one? You've seen me do this several times. I talked about the levels of learning. And I said level 1 is where you know what something is. So for instance, this level 1 knowledge would say, okay, this is called a-fib. Level 2 knowledge says, what do the protocols say to do about it? Not only what is it, but what do the protocols say to do about it? That's where you may memorize things like, oh, well, we're going to put them on an anticoagulant. We're going to give them something for rate control. Maybe that's a beta blocker. Maybe that's a calcium channel blocker. But I want you to at least get to level 3 knowledge where you know the how and the why. Why are you giving them a beta blocker? Why are you giving them a calcium channel blocker? Why are you giving them an anticoagulant? Okay. In order to understand that, we need to understand, for instance, things like autonomics, sympathetic and parasympathetic nervous system receptors, and so forth. We also need to understand things like the prostaglandin synthesis pathway. Okay. And then, of course, level 4 knowledge is where you're able to apply it. You're able to take this same basic concept and go apply it in the brain, for instance, or go apply that same information in the liver or in the kidneys. And then eventually we want to all get to level 5 where we achieve true mastery. And that's where you're able to take something real basic and you're able to figure out things you've never even been taught before. Okay. My job is not to teach you everything in terms of, I'm not to teach you what to think. My job is to teach you how to think. Okay. I'm getting excited over here. Can I get an amen, somebody?